All right, welcome. In this explainer, we're going to tackle the orthopedic side of inflammatory rheumatic diseases. We'll cover everything from what's happening at the cellular level all the way to the surgical techniques you absolutely need to have down for your exams and, more importantly, for your clinical rotations.
Okay, so here's our game plan. We'll kick things off with the autoimmune attack itself. Then we'll look at the clinical signs, the big surgical risks involved, and, of course, the surgical strategies we use. And we'll wrap it all up with the key takeaways.
First up, the autoimmune attack. Before we can even talk about treatment, we've got to get a handle on what's going wrong at the tissue level. So let's dive into the pathology. So what are we really talking about here? Well, these diseases, with rheumatoid arthritis being the classic textbook example, are all about an autoimmune assault. It's friendly fire. Your body's immune system mistakenly goes after the synovium. That's the lining of our joints. This triggers this chronic inflammation we call synovitis, and it can even hit the blood vessels, which is vasculitis. And when that inflammation is just allowed to run wild, well, the result is pretty devastating. This is it. This is the end game of that attack. We're talking about the complete and irreversible destruction of cartilage and the bone right underneath it. This is the core pathology that's behind every single clinical problem we're about to discuss. Okay, so now that we know what's happening on the inside, let's look at the outside. How does all this destruction actually show up in a patient? What are the signs you're looking for? The hand is ground zero for these deformities, and you absolutely have to know these. We've got the boutonniere or buttonhole deformity and the Swan-neck deformity. Both of these come from a serious imbalance in the extensor mechanism, the tendons that straighten your fingers. Then there's the classic MCP ulnar deviation. You'll literally see the fingers drifting away towards the ulna at the knuckles. It's a dead giveaway of joint destruction. And the damage isn't just confined to the joint itself. No, the inflammation goes after the tendon sheaths too. This is called tenosynovitis, and it's bad news. It weakens the tendons until they can just snap. We often see this with the extensors to the 4th and 5th digits, or the extensor pollicis longus for the thumb. And when that happens, boom, the patient suddenly can't lift their finger or thumb. It's a really dramatic, sudden loss of function. And check this out. We talk a lot about the hands, and for good reason, but 90%, 90, that's how many RA patients have foot involvement. It's a staggering number, and it's a huge reminder that you have to do a full body assessment. Don't forget the feet. So with this kind of destruction, surgery is often on the table. We even have a special term for it, Rheumasurgery. But, and this is a big but, operating on these patients is anything but straightforward. It comes with a whole unique set of really high-stakes challenges. So the big question is, what exactly makes these patients such a surgical challenge? Why are they considered so high risk? Well, it's not just one thing. It's a whole constellation of problems. First off, their tissue quality is just poor. It's fragile, it doesn't heal well. They often have systemic osteoporosis, which makes getting screws and plates to hold a nightmare. The vasculitis can mess with the blood supply right where you're operating. You even have to worry about C-spine instability before putting them under anesthesia. And maybe the biggest one of all, they're immunodeficient, both from the disease and the drugs we use to treat it. And that immunodeficiency isn't some abstract concept. It has a very real, very scary impact. Get this. A rheumatoid patient is 3 to 6 times more likely to develop a post-op infection compared to a non-rheumatoid patient undergoing the exact same procedure. That one number changes the entire game. It affects how we manage their meds, what implants we choose, everything. Okay, so we know the risks are high, but what can we actually do about it? Let's get into the surgical toolkit we have for tackling these problems. Basically, our surgical playbook splits into 2 main approaches. You've got your prophylactic or preventative operations. Think of these as getting ahead of the problem, trying to slow the disease down early on. And then you have your reconstructive operations. These are for later in the game, when the damage is already done and we're trying to fix the deformity and get function back. The main weapon in our prophylactic arsenal is the synovectomy. The logic is pretty straightforward. You go in and you physically remove the inflamed synovium. You're essentially taking out the engine that's driving all the destruction, all in an effort to save the cartilage, bone, and tendons from getting chewed up. Now, if we're past that early stage and the joint is already a mess, we switch over to reconstruction. And here we've got a few different tools. We can replace the joint entirely, that's arthroplasty. We can fuse it to make it stable, which is arthrodesis. We can resect or remove parts of the bone. Or we can do things like tendon reconstructions. Let's zoom in on arthrodesis, or joint fusion. This is a really powerful move. What we're doing is intentionally getting rid of a painful, unstable joint by making the bones on either side grow together into one solid piece. Now, there's a clear trade-off. You lose all motion at that joint. But what you gain is stability and, hopefully, a ton of pain relief. So where do we use this? It's a go-to procedure for the small joints in the hand, wrist, and foot. In these areas, having a stable, painless joint is often way more important than having a lot of movement. A great example is fusing the big toe's MTP joint. It creates a solid lever for pushing off when you walk. You almost never see it in a big joint like the knee, though. That's usually a salvage procedure, a last resort. All right, another option is a resection arthroplasty. This is a different philosophy. Instead of replacing or fusing, we just cut out the destroyed joint surfaces. What happens is the body fills that space with scar tissue, creating a sort of false joint or pseudoarthrosis. It's not a normal joint, but it can reduce pain and still allow for some motion. The classic example you need to know is the Hoffman's operation for a badly deformed rheumatoid forefoot.
Okay, we've covered a lot of ground, so let's boil it all down. What are the absolute must-know, key take-home messages from all of this?
Okay, here's the bottom line. If you take away anything, make it this. 1. The pathology is autoimmune synovitis, and it destroys joints. 2. Clinically, know your hand deformities like Swan-neck and boutonniere, but never, ever forget that 90% foot involvement. 3. Surgically, these patients are high risk. Full stop. Think osteoporosis, vasculitis, and that huge 3 to 6 times higher infection rate. And 4. Our surgical strategies are twofold: prophylactic, like a synovectomy, and reconstructive, like arthroplasty and arthrodesis. And that brings us to a final, really interesting thought to leave you with. With all the amazing biologic drugs and medical therapies we have now, the big question becomes, what's the role of early prophylactic surgery, like a synovectomy? When do we pull that trigger? Figuring out that perfect balance between aggressive medical treatment and timely surgical intervention, that's really the cutting edge of how we manage these incredibly complex patients.